Okay. So hi all, thank you so much for attending CMS's Health Equity Conference. This breakout group will be about amplifying lived experiences and frontline findings to foster an inclusive healthcare environment. I'll be your moderator today. My name is Mackenzie Marshall. I'm the Senior Federal Relations Associate at Families USA. We're a leading national nonpartisan voice for healthcare consumers, and we're dedicated to achieving high quality, affordable healthcare for all. A brief description of myself: I'm a female, white, above average height, which I'm very proud of, and dirty blonde. I'm very excited to introduce you to our wonderful panel of speakers who are going to approach our prompt from different angles. I'm joined by Denise Hoffman, who is a principal researcher at Mathematica, Laura Erickson, a social scientist analyst at HHS's Office of the Assistant Secretary for Planning and Evaluation, Dr. Kentrell Little, the founder and board president of the Test Taking Solution Foundation, colleagues Lindsay Galley, the vice president of programs, and Naomi Williams, a patient family engagement specialist at PFCC Partners, Hoang Mai Pham, the president and CEO of the Institute for Exceptional Care, and last but not least, Teal Benavides, an associate professor at Augusta University. A few housekeeping items before we begin. We only have an hour. We're going to make transitions very quick. If you have any questions, please hold them until the end, and then we should have about 10 minutes for a Q&A. So without further ado, our first presentation is from Denise Hoffman and Laura Erickson on improving accessibility to healthcare with equitable communication. Dr. Hoffman currently leads work under the Office of the Assistant Secretary for Planning and Evaluation's Equity Technical Assistance Center to develop trainings, peer learnings, and tools for the Department of Health and Human Services staff to enhance accessibility for people with disabilities, people with limited English proficiency, and to enhance cultural accessibility. And Ms. Erickson has been with HHS for 6 years, and within the Office of the Assistant Secretary for Planning and Evaluation, leads the HHS Equity Technical Assistance Center's approach to engaging expert partners with lived experience. She also leads policy analysis and research related to equity assessments, domestic violence, human trafficking, social capital, and criminal justice. Please welcome our first speakers.
Thank you so much. It's great to be here. So my name is Laura Erickson. My pronouns are she, her, and I'm a white woman. I have curly hair. I'm wearing an orange dress. It's great to be here with you all today. And the office that I'm from in HHS, we do sort of cross-cutting policy analysis and research that serves the whole department. So we're situated outside of CMS, and we help run an equity technical assistance center that serves staff within HHS and helps provide training and tools to ensure that we can do our research, create programs and policies more equitably. And so really excited to be here with Denise Hoffman from Mathematica, who's our contractor on ETAC, as we call it, to discuss a few resources on equitable communications and accessibility, which we created originally for HHS staff. Our leadership has been really focused on ensuring that our programs are accessible for all folks without having to go through additional barriers to access our programs and activities. So with that in mind, and knowing that our leadership is really also invested in engaging folks with lived experience in this work, we created 2 tools that Denise is going to talk about today. And these tools were created directly in collaboration with folks with lived experience across a wide range of topics that HHS works on, who helped come up with the content for these tools and advises kind of on our overall work through ETAC. Let me see if I can advance the slide. Okay, Denise is going to discuss 2 tools in depth. The first is focused on equitable communications and has some tips and guiding questions to help us think about how to communicate equitably with the folks that we're serving. And it's going to cover a few strategies, which include being inclusive and culturally connected, ensuring accessibility and linguistic responsiveness, as well as making information easy to find, use, and understand. And the second tool that Denise will talk about has tips for engaging diverse groups of partners outside of our organizations. So it'll include some thinking about how to actually identify folks that you want to engage, how to reach out to those folks, and then really to build and sustain meaningful partnerships with diverse groups of folks outside of your organization. And we also have a number of other tools at the third link that you see on the slide, including some more tools on how to engage folks with lived experience, do equity assessments and more, which were originally created for HHS staff, but we felt had a lot of applicability to folks in community-based organizations, state and local agencies, and more. So hopefully these will be helpful to folks today. So I'll turn it to Denise with that.
Okay, thank you, Laura. My name is Denise Hoffman. My pronouns are she, her, hers, and I am a white woman with longer brown hair and wearing a navy blue blazer. And I am with Mathematica, and as Laura said, we're the contractor that worked with ASPE and also lived experience partners to develop some of the tools that I'll share today. So there are a lot of tools, definitely encourage you all to check out the website, but the two that I'm going to cover today, we'll go through them sequentially. And the first is on equitable communication. So as Laura previewed, to be equitable, communication should have three characteristics. So the first is to be inclusive and culturally connected. And a lot of this relates to being thoughtful and intentional about our choice of language. So communication should be gender neutral, strength-based, and bias-free. Person-first language is often preferable to identity-first language. So for example, people with disabilities instead of disabled people. And avoid language that reinforces stereotypes such as vulnerable. For example, in the opening remarks today, I heard people refer to underserved groups. So that's a much better language than vulnerable. So you might be wondering, well, how do I know if I'm using the right language? How am I getting this right? I want to be correct here. And so the idea is first to identify and get to know more about your audience, and then work with community members to develop content. And hopefully that's a bit of a theme that you'll see woven out through these tools. The second is about ensuring accessibility and language access. And again, to do this, first identify language and accessibility needs of the intended audience, and then go ahead and meet those needs. So in terms of accessibility, consider universal design so that everyone who wants to access materials can produce materials in common languages. And another tip here is when you write simply, that helps with language translation among having other benefits. And so finally, make information easy to find, understand, and use. And part of this is thinking about length and formatting as ways to convey key information. We don't want to impose cognitive burden of having lots of dense text. Make it easy for people to find what you're trying to say. Call it out for them. And also use plain language. I often hear this explained as communicate as if you're talking to a grandparent. And if you are a grandparent, communicate as if you're talking to a middle school age grandchild. Okay, so on this slide, I have an infographic that has everything that you need to do this well in your work. This is going to be your one-stop shop. All you need is this infographic and you are all set. Okay. So there are some giggles in the audience because there is not a helpful infographic. There is an image load error on the screen. And this is intentional and to mimic the experience of people who use screen readers when information is not accessible. It's really hard to hear that there's something great or helpful or something that you want to know that is out of your reach. So we, of course, want to avoid that in our work. So to avoid pitfalls like the one I just demonstrated, here are some things to consider. First is that automated tools are certainly helpful, but will not capture or cover all accessibility issues. So it is possible and quite common for things to pass 508 compliance and not actually be 508 compliant. And an example that I think has a lot of resonance for this group is that there was an audit of the top 100 hospitals' home web pages, and only 5% were fully compliant with web accessibility standards. So really a lot of room for improvement here. Also ask questions. Are text and images accessible to people with disabilities? What types of disabilities are we thinking about when we're asking those questions? Can people who speak different dialects of a language understand translated materials? And do materials have cultural relevance? And finally, a best practice is to use user testing to ensure that products and services are truly accessible. So building on that theme of including people from the community, the next tool is on tips on engaging diverse groups of external partners. And building and sustaining meaningful relationships requires thought and preparation. So as you prepare, consider why you want representation from diverse points of view. Are you looking to gather perspectives that aren't available on your current team? What perspectives are most helpful? What groups are often underrepresented? Next, set realistic expectations about the resources you need. And so this might include steps such as identifying partners, conducting outreach, and then that important step of relationship building. So start early to do this and build in plenty of time. And also budget and plan for this engagement as you would with any other important input. And finally, be flexible about how you engage with external partners. And this applies both to the mechanisms for expressing interest and then the participation itself. So for example, consider multiple modes of communication. So allowing for written or email communication, phone calls, in-person discussions. So I had planned to do another fake out here related to tokenism, but in the interest of time and also for fear that somebody would take a clip of me modeling that and use it in a different context, they don't want to do that. So I'll make the point, thank you, that we want to focus here on a meaningful engagement and provide an example from the lived experience expert partner group that supported this work that Laura alluded to earlier. So this was a group of non-federal people interested in supporting equity work. And in this context, lived experience means personal background, historical experiences not related to professional or education. And this group consults on e-tax work, including working directly with several HHS offices, and had an early focus on relationship building. And so this relates to our first point, which is to establish relationship before a specific need arises. So in this example, there was a foundation laid before turning to say, hey, can you help us with this task? Another best practice is to provide support for external partners. So for example, this group attends monthly meetings to learn and discuss best practices for consulting and providing technical assistance, and also attended peer learning groups with HHS staff. And finally, when people with lived experience support the work, follow up with your contributors. So in this context, we let the contributors know how their input was used, asked for review of draft products, and also provided feedback. So that was a quick overview of two of the tools. So here are the links to them. Definitely encourage you to check them out. A lot more richness and detail in the tools themselves, and also expansive tools for incorporating equity into your work beyond the ones highlighted. So thank you so much, and available for questions and discussion later. Thank you.
Thank you both. Our second presentation will be from Dr. Kentra Little on lived experiences and frontline findings, a Jackson, Mississippi community perspective on health equity. At the Test Taking Solution Foundation, Dr. Little and her team focus on educating and empowering low-income, under-resourced Mississippi communities with a special emphasis on helping to address healthcare disparities by enhancing literacy. One way the foundation accomplishes its mission is by hosting a weekly radio show on a local public radio station and by providing free tutorial services to students who struggle academically in grades K through 12. Please welcome Dr. Little.
Thank you so much. I call myself going around the other direction. Good morning, everyone, or good afternoon. I hope you enjoyed lunch. I am Dr. Kentra Liddell, and I am a family medicine physician. I also serve on the National Association of Home Care and Hospice Rural Advisory Committee, as well as the Home and Community-Based Technical Expert Panel. And I recently completed a tour of duty on the technical expert panel responsible for creating quality measures for home care and hospice health equity. So again, it's just a privilege to be here. My appointment about which I'm most passionate is indeed being the founder and president of Test Taking Solution Foundation. It is a 501c3 foundation in Jackson, Mississippi. Its primary goal is to enhance literacy, to educate our community about resources that are available, because you just can't act on what you don't know about. And we just think it is so important that that information be broken down on a level that is accessible by even those who live in the hood, if you will. It's just so important that as medical providers, healthcare providers, physicians, nurses, PAs, the entire gamut of those of us who deliver healthcare. So important that we know how to and learn how to access the people where they actually live, where they are. So social determinants of health is a huge focus of our work. And again, I'll just share with you some of the work that we've been doing regarding lived experiences. The Board of Directors and I are privileged to work with underserved, under-resourced, historically marginalized students, scholars who struggle academically. This is just one of the slides that I wanted to share with you to bring home the point that during the spring break, we took advantage of the fact that the kids were out of school. And we wanted to stress upon them information related to English language arts, literacy itself. You know, it's more than just learning how to read and write and spell, but it has also a lot to do with how you comprehend and articulate and express one's thoughts. And so we wanted to meet with the children, talk about not only this topic, but other topics related to health literacy. We have syphilis on the rise again in several parts of the country, including Mississippi. And these are areas of concern that even our youth need to be aware of. And so we made everything, of course, age specific. Social determinants of health, I think I've heard it defined once or twice today already, but it is so important that we keep this definition in front of all of us, because social determinants of health really are drivers of health. They really are. The place where you're working, the place where you live, where you're being educated, where you worship, where you go to get your hair and your nails done. It's so important that we be able to reach people right where they are. And so one of the things that we did in Jackson, Mississippi is partnered, because we know that there are issues plaguing Jackson that plague other places in our country. But I have there on the screen just 3 of our major issues. As you can see, we've had and continue to have a water crisis on our hands. There's a trash collection crisis, which recently was resolved with some temporary measures, and we're hoping really soon that those measures will become more permanent. And also, we have a crime issue. All of these issues impact the health of any community. How can a community be healthy when it's dealing with these type issues, as well as systemic racism and discrimination on many levels? And again, we are talking about a state in which I love, but it's Mississippi. I pause, and I have to, because now our city is the crime capital of the country. We have some of the worst health indices in the country. Our chief medical officer over the State Department of Health cares very deeply about these issues, and that is why we partner with them to increase education and knowledge about 2 cancers, for example, breast cancer, cervical cancer. We use the literacy hour to do this, and that's just our radio station. We have on first Tuesday talking about educational literacy, second Tuesday, health literacy. We talk about financial literacy concepts. The show reaches over 1,000 listeners each week, and they call in and they tell us the impact that it is having on their lives. It's been very successful thus far. We mix, of course, comedy and laughter with our messages, because we know that music, laughter, comedy helps to reach the masses, particularly in this community. Our children even came up with a song entitled Water. And this song really talks about how this issue has impacted them. Imagine, some of these children have never drank from a water fountain because the water has been bad. And so in their elementary schools, they've been barred from drinking from the water fountain. So talking about safe and healthy water, right? It's a very, very important topic to explore, and I'm just so glad that we're here today and able to do so. Breast cancer has a great 5-year survival rate. And one of the messages we're able to share on the Literacy Hour is that early detection saves lives. So that Literacy Hour show has been one of the most important modalities that we have used to reach the community. Our elders who come to our foundation to utilize the printers, the copiers, computers to gain internet access. And so this is just us in the grocery store. We take our message again to where the people are. And here we are outside of a gas station. We have now a challenge because that grocery store just closed at the end of May, leaving in that community yet another food desert. I'll end there. My contact information is on the screen. I could have stayed here all day talking about every aspect of each of those slides I showed you today, but we were allotted a certain number of minutes and I've stayed within that time limit. I will answer any questions once we begin to do Q&A. Thank you.
Thank you, Dr. Liddell, and thank you for staying within the time limit. That's wonderful. Our third presentation is from Lindsay Galley and Naomi Williams on unlocking diversity in patient family engagement for equity and inclusive environment for all. Both our speakers are from PFCC Partners, which has a mission to facilitate equitable collaboration among healthcare stakeholders, including patients and family caregivers. In her role of VP of programs, Ms. Galley supports authentic collaboration between patients, organizations, and family caregivers with the goal of promoting improvement in their organizations. She uses her personal healthcare experience with a blood clotting disorder and her passion to develop and implement programs supporting partnerships in healthcare as a fuel for her work. And Ms. Williams, a patient family engagement specialist, comes to her work with over 20 years of educational and professional experience. Naomi has a personal experience that connects her to the work as well. In 2009, Naomi's disability advocacy, along with community and organization education efforts, were enhanced when she became a parent to a 26-week micro preemie and began the journey of raising a child with complex health and medical needs. So please welcome Ms. Galley and Ms. Williams.
Thank you. It's great to be with you all today. I was saying I'm gonna have to wing it. It's up here now. I am Naomi Williams. My pronouns are she, her, hers. I am a Black female with curly textured chin length hair. I am wearing a blue shirt and a multicolored skirt. I come to you from Muskogee County, which is in Augusta, Georgia. I am with PFCC Partners, which is based out of Los Angeles, Long Beach, California. We were founded by Libby Hoy, who is the married mother of 3 boys who live with mitochondrial disease. Having gone through the healthcare system on her own with her boys, Libby noticed the difference of working with the healthcare systems and the difference it made when people who had lived experience were able to be a part of the process. We know that healthcare is a multifaceted and very complex system that has a plethora of providers that amasses trillions of dollars in providing care. A key piece that is missing is working with those who have lived experience. PFCC Partners, let me slow down, getting tongue-tied here. PFCC Partners, we work as the catalyst for change. We are committed to being a catalyst of change in healthcare. And what we have found, one of the ways to do that, and the missing piece of that, is incorporating and including those who have lived experience. So in my bio, I am the proud mom of a micro preemie who lives today with significant disabilities. Being able to connect with others who have to navigate the healthcare system are the ones who are going to be able to help change the healthcare system. Connecting with individuals that have lived experiences are the ones who are going to be able to reach the communities that you are looking to connect with. Not at the back end, but starting at the very beginning. So not when the programs are all put together and say, oh, well, let's see how this is going to work. And then you go into the community and you hear they blow up your whole plan. You're like, well, that's not what we came here for. But you came to hear what it is that we need. So with PFCC Partners, what we have found to do is to be that bridge between the communities that have lived experience and working to partner with the healthcare systems. So as you see on the slide, and if you don't, there's a lot of different dots and a lot of different lanes. So we work to connect the dots. Over the last 2 days, that's what we've been hearing from the various offices about connecting with individuals with lived experiences. For those who have lived experience, we know this, and we're looking and wanting, people want to tell their story. One of the things that we found, so I'm going to tell you a story. We worked with the organization CHCS as they were putting together a framework with changing some healthcare. We had one young lady who has a lot of lived experience. She was attending, but she was not understanding a lot of the conversations that we were having. But she showed up every month. We were doing this virtually. There were some tech issues, but she showed up every month virtually. Connected with her outside of the meetings. She would call me Naomi. I didn't understand this. So we would go through things. She sat and participated on this project for 9 months. It was in the 8th month when we had a conversation and she started talking about all the notes that she had been taking virtually over the last 8 months. And as I listened to her, I said, oh my God, yes, you got it. We need to hear, you have it. Even though you didn't understand a lot of what was happening, you showed up, you took notes, and you were able to regurgitate what you heard. And by you telling me what you heard, I can help our partners figure out where your lived experience impacts the program that they're putting together. We can't leave our partners, those with lived experiences, on the side. When we talk about making it equitable, and Lindsay will talk about this in more detail, when we talk about making it equitable, it's not just going to individuals with lived experience and saying, we need your help. It's time, it's energy, it's money. So when we talk about equitable, it's not just hearing from me, but are you going to compensate me? How can you compensate me and not have me go over the benefits cliff? So getting creative with compensation. Does it fall within your time frame or my time frame? Are we doing it 8 to 5 or are we doing it 6 to 8 p.m.? So looking at different things. So one of the things that we have that is working well with PFCC Partners, among the many things, is our PFA network, where we are able to connect. We have a huge hub, and we have over 1,000 people that are involved with our network to be able to engage in opportunities. We do skills development, exchanges, as well as continuing to build a community where not only can the health providers connect with them, but where partners, PFA partners, patient family partners can connect with each other. So with that, I'm going to turn it over to my colleague, Gally, so Lindsay, and where she can share the rest.
Hi, everyone. Thank you, Naomi. My name is Lindsay Gally. I am a female. I am white with long, curled, brown and blonde hair that needs to be touched up a little bit, I know. I'm wearing a burnt orange shirt with a black blazer. And I'm going to talk to you about cake, right? That's what we're all here for. No. So to have the privilege of creating an inclusive environment for partnership, we need to create doors in the community that allow people to share their perspective in order to advance improvements in health equity. And our organization likes to have fun. So we call this the Funfetti approach to partnership. If you haven't had a Funfetti cake, first of all, this one on your screen is from Milk Bar. Has anybody heard of Milk Bar? Oh my God, it's so good. It's so good. So it has a rainbow of different colored sprinkles baked into its many layers of cake. The Funfetti approach is meant to bake in partnerships with people with lived experiences at every level or layer of healthcare, from bedside to organizational improvement to community engagement. Whatever the healthcare improvement topic is, we can apply patient-family engagement for equity as an active strategy to reach the outcomes we all want to see in healthcare. So equity is the key ingredient to the Funfetti approach, expanding the ways in which we engage what our organization calls patient-family partners, which Naomi shared, or people with lived experiences, people who use their lived experiences to influence healthcare. Will diversify the perspectives, including voices that have been traditionally underrepresented in engagement efforts. The key is, as I said before, creating more doors to partner in more places in the community. For example, hosting listening sessions at community churches or having a community conversation at a family resource center with moms. By engaging diverse populations in inclusive activities, together we can co-design strategies for closing the gap in disparities of care. So for example, what can we learn from patient-family partners about social drivers of health screening processes? This slide illustrates what happens when patient-family partners aren't engaged on the right and what they can contribute when they are engaged on the left. I think I got my sides right. Instead of going through these points, we heard that there was a hunger for the sharing of lived experiences. So I recently sat down with a patient-family partner who has complex social needs, and she shared her experiences being asked about social drivers of health during a recent doctor's visit. So I'm just going to read what she shared with me. She shares, I recently completed a social drivers of health screening that was a checkoff list of things that you need and things that you don't need. A lot of it was driven more towards the mental health aspect, which is really nice to see and a good start. But we need to see a little more activity for the actual social drivers. Are you able to pay your bills? Are you able to feed your family? I saw a couple of questions like that, and I answered them honestly. And frankly, the biggest concern for that is I got a little messed up. Frankly, the biggest concern for that is I gave real honest answers and they didn't have any solution for me. It's frustrating to be put in a vulnerable situation of having to describe very personal feelings of how things are going in your house and your ability to take care of your own family. And when you choose to be vulnerable in that aspect, and then they say, wow, we wish we knew what to do to help you. If you aren't going to know how to help me, I just wish you wouldn't ask me. So that's what we're hearing from patients and families. So how can we take that perspective and improve our processes and how we're asking these questions, how we're connecting people with the resources that they need? So how? I already talked about a few of these things and I have 2 minutes left. So I talked about creating multiple doors in the community, going to where people are. Next, representation matters. I believe it was Tequila Terry yesterday afternoon who talked about the birth centers that have people with lived experiences on the care team. The same goes for engaging patient-family partners. Our office administrator, Lucero, hi Lucero, I think you're watching, hi Libby too, will be working with our Los Angeles County Department of Health Services Patient-Family Partnership Hub because she is truly representative of the Los Angeles community as a bilingual Latina. So really having those that are representative of the people that you're speaking to, it really matters. What else? Naomi mentioned compensating time and effort, really, showing people that your time is just as valuable as the time that you're putting into it. We do use ground rules to promote inclusivity. I'm happy to share those afterwards, but it really, especially in listening sessions or focus group community conversations, it puts everybody on the same page to be able, my favorite ground rule we use is take space and make space. So take the space you need, but also make space for others to share. And finally, and one of the most important ones, and I think ones that the tip that gets lost the most is closing the communication loop. So you're listening to patients, you're listening to family caregivers, the community, you're going back, you're making all these changes. And then what? You know, they need to see the impact that they're having if you want to continue these engagement processes and create trust and continued engagement and partnership in the community. So thank you so much for your attention today. I really appreciate it and look forward to any questions that you have.
Thank you both. So our fourth and final presentation today is from Teal Benavides and Dr. Honmai Pham. I'm saying that correctly, right? Pham? Mai, it's fine. Okay. Their presentation is titled Standardization Does Not Equal Equity, Supporting Health Outcomes That Matter Most to People with Intellectual or Developmental Disabilities. Dr. Teal Benavides is a wife, mother, occupational therapist, and health services researcher. She is a tenured associate professor at the Institute of Public and Preventative Health at Augusta University. Her work fosters access to services for autistic people and others with intellectual and developmental disabilities through community engaged approaches and applied health services research using large-scale data. And then Dr. Pham is the president and CEO of the Institute for Exceptional Care, is a general internist and a national health policy leader, and a mother of two beautiful young men, one of whom is autistic. The doctor previously was the vice president of provider alignment and solutions at Anthem. And prior to Anthem, she served as the chief innovation officer at the CMS Innovation Center. Please welcome our last speakers.
Hello, everyone. I'm honored to be here with you, and I want to just echo what all of our speakers have shared before around the importance of stakeholder engagement in promoting health equity. I am a white female, and I am wearing a teal colored blazer. I have medium length brown hair with gray streaks, and I'm wearing black pants. So as we get started in thinking about health equity for people with disabilities, we know that there are critical access concerns and disparities in health outcomes. People with intellectual and developmental disabilities in particular have a myriad of needs across the lifespan, ranging from their early childhood all the way up through adulthood. And in our talk today, I think the main point that we would like you to take away is that understanding and listening to the lived experiences of people with disabilities is equally as important in addressing health equity through top-down approaches. We've heard in many other sessions that we need to inform those top-down approaches to health equity with the voices of people living with things that affect their ability to access healthcare and the services that promote health and well-being. In our presentation today, we're describing what we learned through a PCORI-funded capacity building project to understand the priorities of people with intellectual and developmental disabilities, care partners of people with intellectual and developmental disabilities, clinicians, payers, and regulators. All of these individuals joined with us to lead the conversations, were paid in a fair and equitable manner, and we used approaches that were described by our previous presenters to improve the way in which we offered communication access, we offered multiple doors for people to engage with us, and we promoted the closing of the loop in all of our engagement. So what did we do? We involved a variety of individuals across different experiences. More than 130 people talked with us about what health meant to them and those health outcomes that they felt were important to achieving their health goals. In our project team, we involved researchers, nonprofit leaders, people with IDD, care partners of people with IDD, clinicians, payers, and regulators on our core team to inform how we engaged and the work that eventually resulted from our capacity building efforts. We used one-on-one sessions to engage with our partners, focus groups, written and other kinds of approaches to support the engagement of our partners in many different ways. And just like Naomi mentioned, we connected with people after sessions to be sure that the larger focus groups met the needs of some of the individuals who might have had a harder time understanding the concepts that other members of the focus group were bringing up. We have a wonderful stakeholder engagement lead, Dr. Malin Andreessen, who worked hard to ensure that all people had access to the capacity building efforts to understand priority outcomes. In the next few slides, you're going to see some of the preliminary health outcomes that we've heard are important to people with IDD. These include being able to make my own healthy choices, improving my emotional and mental health, improving my physical health, reducing pain and increasing energy, being able to do the things I love and need to do, and family care partner wellness and support. The first priority health outcome, making healthy choices, includes a number of different elements that we heard were essential for people with IDD to support making healthy choices. This included things like addressing sexual and reproductive health, having a provider who spends time with me, having a provider who refers me to supports in the community, supports for family care partners, and in lifespan approaches to address well-being across the lifespan. The second health priority outcome was emotional or mental health. People with intellectual and developmental disabilities and their care partners shared that self-advocacy, self-determination, and accommodations, when supported, promoted their mental health and well-being, as did referral to counselors who understood how to work with them as a person with an IDD, adapted and tailored mental health interventions that did not rely on talk therapy, access to peer mentoring and supports, and learning strategies that they could use in community settings, such as mindfulness, that did not rely on an outside provider. The third priority health outcome included physical health, addressing pain, and improving energy. People with IDD consistently shared that shared decision-making was essential for this priority health outcome to be a reality, although they did not often receive the kind of presumed competence and respect in those interactions to promote shared decision-making. Providers who spend time with me was essential to achieving this health outcome, as was care coordination. What PFCC Partners talks about is connecting those dots and creating partnerships, understanding and sharing information about how pain is manifested differently and when limited communication is happening, and dental care, schools as important settings for health, and community available resources. The last health outcome I'm going to describe is doing the things I love or need to do. People with IDD shared that living in an inclusive and caring community, having the resources to live somewhere safe and accessible. This included physical and emotional safety, supporting those physical and emotional safety elements wherever that person was receiving care. Person-centeredness and reliable transportation were critical elements. These are those social drivers of health that we keep talking about, and people with IDD and their care partners express the importance of these elements. I'm going to turn it over to Dr. Mai Pham to continue sharing some of the elements related to the priority health outcomes.
Thank you too. And I'm middle-aged, so I'm going to have my own slide deck here. I am a Vietnamese woman. I am by far the shortest person in the room, and I have dark brown hair. And to make up for my height, I'm wearing a bright yellow blazer. So as Teal said, we identified those key priorities by talking with community members, but then we also asked care partners and clinicians and payers, how can they support those outcomes. And here are some of the themes that came up. One major area that payers and regulators brought up were these issues around the things that stand in their way of supporting community members. They would like for health outcomes framework, what we're developing, to formalize these themes that we heard. They also want to know, though, information on where they should invest their dollars to best support community members. And they would love for CMS and others to make the regulations and policies surrounding care of people with IDD more flexible so that they can tailor their approaches in what they cover and how they pay for it. They also really welcome direct collaboration with both clinicians and community members. When we talk to clinicians and the other stakeholders, they also pointed to a whole bunch of what they called system supports that need to wrap around the clinicians and patients and payers. That included things like, there are too many here for me to read out, but it included things like having measures, quality measures that actually reflect what matters rather than what is easy to measure. Having navigation supports to help a person so that you don't need a PhD in social work to get to the services that you need. And having a co-location of different services so that people for whom transportation or getting time in the day or bringing along a support person are really burdensome don't have to make multiple trips. And then clinicians in particular, we were really pleasantly surprised to hear them say things like, we want more training. Help us get more training. And they also said, we want to give more time to patients who need it. But the way that the payment system is structured now, we don't have that time. We want payment to change so that we can give patients, each patient, what they need instead of a cookie cutter approach. And so just knowing that there is a willingness there, I think was very encouraging. So in summary, after talking to more than 130 stakeholders, we really do feel like we came to a consensus on what health outcomes matter most for people with IDD and the people who support them. We learned that empowering people with IDD and offering them, ensuring self-determination in their health decisions, as well as supports for true shared decision-making, are really essential ingredients. And system barriers are presenting problems for everyone involved. The opportunities are too many to list, but some of them include having better communication of goals and priorities between people with IDD and the healthcare providers who serve them, increasing evidence for and payment for specific types of supports that get to these health priorities, and then ensuring that clinicians get the training they need and want. Medical students get an average of 11 minutes of exposure to IDD, and I'm pretty sure I got none. Some policy and practice implications from our work, if you stop and think about all of the things that we outlined to you today for 30 seconds, you will realize that there is almost nothing that is IDD specific about them. These are just things that human beings want. And we think that that is a really important takeaway. Many of these priorities, however, are going to require a new way of measuring outcomes that are more person-centered, that are not driven by clinical guidelines, which our stakeholders not think were particularly relevant. Flexibility in laws and regulations, and then aligning the definition of IDD and how services get decided upon across different sectors like clinical services, education services, home and community-based services is super important. And then all of these stakeholders who serve community members wanted more training. There is a really deep hunger out there. I think we all felt that they felt emotionally inspired by their interactions in this project, and they want more. We need to help them get that more. In terms of next steps, we will be facilitating a large multi-stakeholder meeting in mid-September this year to finalize the health outcomes framework or finalize the draft of the health outcomes framework. And in preparation for that, we're holding 4 prep meetings, walking through different decisions to narrow down the priorities. And what we hope to do is to release a full draft before the end of the year for public comment. And we really encourage all of you and invite all of you to follow that because, as I said, these are just human being outcomes that matter. And we want this project to be that tip of the spear that gets policymakers and healthcare teams to think about what quality means differently. Thanks very much.
Thanks. Great. So we actually made excellent time. So this closes out the presentation portion of the breakout session. And now we can turn to Q&A. So we have about 7 or so minutes for questions. So would anyone like to volunteer the first question? Yeah. Do we have a microphone for you? Yeah, if everyone wants, that'd be great, actually. Just have the whole group up.
Hi, good afternoon. Thank you all so much. This was a wonderful, wonderful presentation. As a person that loves or that did a lot of qualitative interviewing, it's like touches my heart very much. My name is Shireen Huck. I'm from Humana and I work on their health equity team. So I have a question. So how do you invite people to participate and share their lived experiences in ways that doesn't stigmatize the population?
So if I repeat this question, tell me if I heard you correctly, because I was on the end. You said, how do we engage people in sharing their lived experiences without stigmatizing? Is that the question? That's a great question. So I think one of the ways that we heard our partners share and that we did as well in our Ideal project is we learned from those individuals in previous work and previous projects, things about language that people preferred. So we heard about using person first versus identity first. And you heard in my introduction, I actually have the term autistic individuals, and that's from engagement with people on the autism spectrum that they prefer that term. So we've worked collaboratively with our partners in many different contexts to understand language, communication preferences, and set up the environment so that the environment that we're involving people within doesn't additionally stigmatize or marginalize those communities. And we've set up ground rules, we've set up an engagement and compensation guide, all informed from the people with lived experiences. So they're telling us what is stigmatizing, they're telling us what language not to use, and all of that is built on a foundation of trust. And so it all starts with building a trusting environment and learning from them what is stigmatizing and not, and allowing them to share voice to those concerns that maybe have happened in other settings that were not so good.
I'll just add, oh my gosh, I forgot from here to there. I was going to say definitely building trust, but what we typically do is put out just broad invitations and people can select in to any opportunity that they see themselves in. So I think that's just another way, to not stigmatize any specific populations, is let people self-select into opportunities that they feel that they can have an impact in.
Go ahead.
So I wanted to comment on the last thing, because I think it's their process is one which is highly generalizable to inclusivity. Because if you go in with a formal process that is simple to understand, there's the whole question of simplifying language so that everybody understands, that's going to bring people in without stigmatizing, without labeling. It's so that's just a comment.
Any other questions?
I think we can move into our Zoom questions.
Okay.
Our first one is, as an acupuncturist, we provide a cultural medicine that is being rebranded. Just wondering how our profession can be included in the discussion of healthcare and how we can stop the rebranding of acupuncture and Chinese medicine to include us versus replace us.
Yeah, so this is if I'm speaking from the Ideal Project. We didn't have a chance to share with you all of the detailed input that we got, but in that domain of improving my physical health, reducing pain and maximizing energy, as in some other domains, our community members said, we really want healthcare to think outside the box. We don't have an inside the box set of problems, so you can't come at us with an inside the box set of solutions. And medication cannot be the first reaction to every problem that we have. And so they actually called explicitly for alternative modes of therapy, whether that's for, psychological, emotional support, art therapy, music therapy, or for pain control, things like acupuncture or mindfulness. So there's an explicit call for that. And I think that that's what we need to honor as we move forward.
Thank you.
I think we have time for one more.
Perfect. Our next question, do you have suggestions for making a good case for compensation of lived experience contributors? I work in an agency that doesn't understand why this would be necessary or needed, yet they want to increase our engagement with lived experience groups and folks from historically marginalized populations.
I'll take that one. This
Lovely.
is this is Naomi, because I was one of those people. So when you're talking about engaging with those with lived experience, I am no different than you. The people in your community are no different than you. They have bills. They may have childcare. They may not be able to work depending on what their ability or disability is, but it still comes down to time. So this is what I would say. If you don't want to compensate, which I don't promote that, but do it after your work hours. So come at 6 and go into your community and work with those. Unconventional, hi Libby. But it's important because you get paid for your education, for your work experience, for your knowledge. So why shouldn't those who have lived experience that you need to know how to make things better get compensated for their knowledge and what they have walked through?
Thank you.
Okay. Awesome. Well, thank you all so much for coming to the breakout group. And can we just do one more round of applause for all of our speakers? They did such a great job. Great. Well, I hope you all have a great rest of the conference and stay inside, please.